The macro issue of a population bomb is something that's been of interest to Barry Siegel since the moment I met him, and for a lot of years now, since he first visited East Africa. And we've sort of come at it through this sort of macro view as well, that there's this big ambiguous problem which, because it's so large and so ambiguous, sort of causes us to be somewhat apathetic towards it. So I think what this next panel will do, and something that Valentina will be doing, is sort of connecting this macro issue, something that affects all of us, and putting a more personalized individual side to it. Because at its essence, population issues are next to family planning, which are next to reproductive health, which are next to the individual rights of women and girls especially. We have a lot of folks, like Martin mentioned earlier, who are much smarter than ourselves, who are going to speak intelligently about this for the next hour. So I encourage you, even if it doesn't seem like it's really directly related to the work you're doing every day, to think about it as a sort of supply and demand issue, right? 90% of the folks in this room are working on supply-side solutions, building more classrooms, training more teachers, educating more kids, creating more jobs. But we're sort of constantly in the tail of a comet, chasing after what's a sort of a burgeoning demand. So these folks will talk a little bit about the demand side of things. We can make this controversial. That's something that we like at the Siegel Family Foundation. So I encourage you guys to ask the tough questions. Dr. Tarek McGueed from the University of Nairobi Medical School will be moderating the panel with a bunch of stellar all-star folks.
I just have to correct you, Andy. I'm sorry, I'm not from the University of Nairobi. The University of Namibia. And Namibia is different from Kenya in many ways. One of which is, it's a big country and we have only 2.5 million people. And still contraception is a big issue. I want to introduce the panel to you. And the idea is that each panelist will introduce herself or himself and give us an idea of what they are doing and why what they are doing is maybe different from what other people are doing.
Hi everyone, my name is Layla Darabi and I am with Planned Parenthood Global, which is the international division of Planned Parenthood Federation of America. And because I get this question often, the International Planned Parenthood Federation is probably an organization you've heard of. That is the world network of reproductive health care providers. Planned Parenthood in the US is the US Member Association, but in addition, through Planned Parenthood Global, we support partners in 10 other countries, 5 of them in Africa, with technical assistance and financial assistance. And the programs that we support focus on advocacy and healthcare delivery, specifically reproductive healthcare delivery. And we over the years have been varied in size. And right now, focusing just on 10 countries, we like to think of ourselves as an incubator and a developer of models. And so, to answer the question of what is innovative about Planned Parenthood Global, what do we do that not everyone else does, I thought I'd give you a few examples of some of our partnerships. We have several models that we have developed with individual in-country partners and are now trying to codify in manuals and share with other partners. We like to say that we enter partnerships with an exit plan. Our typical partnership is 5 to 8 years, and we have a big emphasis on sustainability. Our overall goal is to help grow civil society in the countries where we work. We work with a lot of advocates, and I know we focus mostly on healthcare delivery here today, but one of the reasons we partner holistically in countries is because we believe that advocacy and healthcare delivery are very linked. And a lot of our advocacy work is focused on convening groups who might not otherwise have a space to meet together. So we bring together youth advocates, healthcare professionals, the nurse associations, doctors associations, women lawyers, and have funded and given a lot of technical assistance to the coalition in Kenya that helped pass a new constitution that has greatly expanded women's rights, to the coalition in Guatemala that passed a safe motherhood bill that now guarantees free maternal health care for all women in Guatemala, yet to be fully implemented, but on the books. We were talking at lunch about what does it mean to be sustainable, how long is, there's sort of a balance between organizations giving technical assistance, big international organizations coming in and swooping in and leaving, and starting some momentum and letting the project fizzle out. And then there's the flip side where if you're truly trying to partner for a sustainable project that can stand on its own, you have to know when that project can stand on its own and walk away.
My name is Raj Punjabi, and I'm here with Tiatine Health, which we've been very lucky to be a partner of the Siegel Family Foundation this year. also with Harvard Medical School in the Division of Global Health Equity and as a physician there. And we in Liberia do something very simple. We're employing local villagers, women, former patients, former refugees to serve as highly skilled frontline health workers with the goal of trying to save lives in very remote villages in Liberia. I guess I can speak to this from a couple of perspectives as a caregiver in the country that I grew up in, that has gone through so much in the last 25 years. But also as a dad. I just became a dad 4 months ago, and I don't think I ever understood as I do now how watching my wife take care of our son. Last night he had his first cold. And so just watching the power of her love, and actually I think it's hit to me that there is no job more important than motherhood. And I think a lot of people would resonate with in this room. And the components that go into women's health, access and the right to family planning is of course a huge part of that. In Liberia, we're trying to work on this problem that's facing so many countries in Africa, which is the shortage of health workers. There are about 1.5 million health worker shortage on the continent, mainly in rural areas, where access to family planning, where access to women's health is, as Barry noted this morning, the worst. And there perhaps is no country or very few countries like ours that has seen such devastation and a shortage of health workers. I was 9 years old when the war happened, and my family and I fled and left the country, went to Freetown, eventually got resettled in North Carolina, and I went on to become a medical student and went back. And when I came home, what I saw was utter destruction from the war. We had one of the worst mass exodus in doctors, perhaps in history. 51 doctors left to serve a country the size of Ohio. In the middle of all that, and we'll talk statistics later, but let me just share with you the kind of things we were seeing at that time. In rainforest communities, rural villages, the men in our country, where women have been violated for so long, it's the men who are talking about the fact that their mothers, their sisters, their wives are dying in the back of sheds because stuck in labor, they know what's wrong, and they can't take them to a clinic because it's 15, 17 hours walk to get there. They hoist them on hammocks only to walk through the forest and then perish. It was in the middle of all that we decided for women and women with HIV that we were not going to let people die just because they lived too far from a doctor. Employing the people from those communities to be part of the formal healthcare system and bring healthcare out to these villages that had never had healthcare before. About 50% of our population, global population, has absolutely no geographic access to healthcare. And that's exactly where the mothers die the most. 1 in 15 mothers die in our country. 1 in 15 women will die in our country just because of complications of childbirth or pregnancy. That's worse than how many women were actually died from complications of being raped during the war. And yet no one's outraged in the same way about this very fundamental right. What we were told when we started our work, we started out with a gutted bathroom in the hospital and with some wedding donations. We were told that we were naive for trying to take care of women with HIV and provide care to mothers with HIV, from people who were 25-year veterans with huge international groups. We've now gone as far as we have, and I think still that cynicism exists among a lot of groups, and I think the work that's happening here is disproving that, but more of that needs to happen.
I'm Bill Ryerson. I serve as Chair and CEO of the Population Institute in Washington, but the reason I'm here is my serving as founder and president of the Population Media Center, which is based in Vermont. The proposed plan of action at that UN conference did not mention the status of women. So together they crafted a paragraph on the status of women and took it to one of the members of the US delegation to this UN conference and said, this plan doesn't mention the status of women, so we've written a paragraph we would like to have you propose as an amendment to the plan in the plenary session. Could you do that for us? And this delegate said, well, this is a meeting about family planning. What's the status of women got to do with it? So we've obviously come a long way since that time. The 1994 conference, which I also attended in Cairo, really laid out for the world the interconnectedness of population reproductive health and the status of women and girls. The world has made a major effort to at least get condoms and other methods available through kiosks, even if there isn't adequate care. So in many places in the world, people can find a contraceptive. It may not be the contraceptive of choice, but they are there in village kiosks. And when you look at the countries where the demographic and health surveys have been carried out, it is clear that the top reason for non-use is wanting more children. When you take those people aside and you look at just those who do not want additional children, these are the top reasons given. Wanting as many children as possible is number one, fear of side effects, male opposition, fatalism, and religious opposition. So unless ideal number of children changes, the fertility rate is unlikely to come down. And this is true in much of sub-Saharan Africa. In Ethiopia, 18% of reproductive health clients cited our first program. We're currently producing our 7th nationwide radio serial drama there, with half the population of the country listening. And this is one of the reasons we're using soap operas, because people don't go home in the evening to listen to public service announcements and documentaries or to hear about AIDS. They're interested in being entertained and relaxing. So we do gripping, emotion-based programs in which people fall in love with the lives of the characters, and then over several hundred episodes, those characters, through gradual evolution, can have more influence on the audience without ever telling the audience what to do. We've done 2 programs. Our second one in 4 northern Nigerian states was listened to by 72% of the population at least weekly. And at 11 family planning clinics, when people were asked why they had come in, 67% of them named that program. So this strategy is clearly not only effective, but from our standpoint, the most cost-effective per behavior change strategy that we've been able to find anywhere on the planet.
My name is Sajida Amin. I work as a demographer for the Population Council. I also serve on the advisory board of BRAC USA, which is a Bangladeshi, now international global development organization that does community-based development. My main focus that kind of connects my demography work with BRAC is that I've done most of my work on youth, how to empower young people, especially girls. And I've been fortunate to be trained as a demographer during a time when population was still in vogue, and before it went out of vogue and now I'm kind of already seeing the resurgence of interest in population issues. The big challenge for us who have kind of understood what the population issues are is to use this moment of when people are rediscovering population issues, and to highlight how this recognition of population has to be different in 2012 than how it was received and perceived in 1974 and in 1994. The big challenge, as Bill mentioned, is kind of making the connection with the status of women. And I would say much more specifically making the connection with young people. We know that in terms of demographic transition, in terms of population growth, the biggest growth is going to be in the population of young people. And we know that the challenge in terms of changing people's fertility behavior is not in terms of information, as Bill mentioned, but in terms of translating knowledge into behavior. And that's where empowerment of young people comes in. I've been fortunate in the last few months, BRAC has asked me to advise them and to help them write a strategy paper on how to refocus their whole development agenda. You know, they've been working with over 100 million people all over the world to refocus that into something that harnesses the potential of young people. This mandate is very, it's been very useful for me to engage with BRAC on this very particular, very specific challenge, to see the kind of receptivity with which they have embraced kind of our demographic analysis of where the world's population is and where it's going. And I've seen kind of how the power of evidence, which is the central mandate of the Population Council, how that can be harnessed to actually do some practical things on the ground. There are 2 or 3 big challenges in this. One is kind of being a research organization. It's very difficult to get the kind of support that you need to do research right. It's expensive, evidence gathering is expensive. That's one. Number 2, because of the kind of research we do in terms of assessing what works and why, you need a scale of evidence gathering, but you need a sort of, to use tools that are not always very easily understandable or easy to communicate on. So kind of the whole challenge of keeping it simple is a core challenge for especially for the quantitative research that we do. We are used to think about young people in terms of problems. It's a little bit harder to switch, especially in this kind of context where you're talking about population problems, switch that conversation around to talk about the potential of young people and to talk about young people in terms of the opportunities rather than the problems. But I think that's where the crux of the matter is to talk about harnessing the potential of young people in positive terms. And finally, in terms of empowerment, empowering people to do what they want, empowering the most vulnerable, the most disadvantaged segments of young people. I find that sort of the whole sort of teaching tools for young people to exercise their notion of rights, their realities is a real challenge.
But if there is one thing that is really taboo over there, it's sex. So how do you have already like a process in place that maybe our staff on the ground can address those little girls with their education and to the mother of the village, how to handle this thing in a very sensitive way, and also how maybe to talk to the fathers to try to handle this situation? Do you have like a case scenario where we can just copy the model and try to adapt it to the sensitivity of this village?
I mean, yes and no. I think that there are other organizations that have some of those models. I know IPAS has a very well-known values clarification exercise that is really useful for talking about taboo topics like adolescent sexuality, like unsafe abortion, things that we know affect communities but are very hesitant to address. What Planned Parenthood Global has is a training the trainers manual so that other healthcare organizations who work with community healthcare workers can train young people to be youth peer providers. One young man, like the biggest young man, played with the pastor, and all the other kids played a community meeting, and somebody walked in and said, "Hello, community meeting. I think this community means contraception and family planning." And the guy playing the pastor jumped up and said, "No, no, 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 God, 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 God." And everybody else jumped up and in unison pointed to him and said, "Be a true man of God. Be a true man of God. Help the women." And for me, that was such an awakening, because I saw that I could never have explained it that way. I could come in and say, these are the health benefits, and it's over the counter, and blah, 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 and we can connect you with supplies. But it was that very community explanation of, we have assessed our opposition to birth control and our opposition to women dying, and we have determined that our opposition to women dying outweighs our opposition to contraception.
Can you tell us just briefly what you accomplished in that hospital and what you did to slow down pregnancies?
We built 2 new maternity hospitals in Malawi, which were the first hospitals, which are still till now, the first hospitals, the only hospitals in all of Africa, where all women deliver in their own private rooms. So that means they can have their husbands, preferably the husbands, but anyone with them. And they are not, if you go to a normal public hospital maternity ward in a poor country in Africa, it has an atmosphere of veterinary medicine over it. There's no doubt about it, and that's also how women are treated, and that's not the case anymore there. The idea, philosophy behind that was to show respect for these human beings, but also to kind of give space to them to find out what they want.
Looking up these two organizations, the two of you are here from, the Population Institute and the Population Council, and then I Googled population bomb, and I found a significant number of articles written by people who say that it's a myth. So can you say something about the most common arguments that it strikes me as sort of similar to people who deny that global climate change is a reality. But can you say something about the common arguments that they make and the agendas of those who make them?
There is a belief, number one, that there are no limits. And I've heard people say the idea of limits are crazy. That indeed human ingenuity will overcome any possible limit of resources, limit of nature to absorb our waste, etc. These are people who are not trained in ecology. But more powerful and more fundamental to the funding of opposition to stabilizing population are the economists, who think that there's no limit to economic growth unless the population stops growing. So they see the idea of a bigger pie is the goal here, not a bigger slice of the pie per person. And there is tremendous opposition to promoting smaller family norms, for example, by some organizations who just think the idea of slowing population is a way to ruin the economy.